as we know, one person does not achieve anything, and what is good and what actually is valuable to us all is usually the result of collaboration and team working. And so Donald is there. Nothing is done in isolation. So I have to thank loads of my colleagues for any compliment in relation to Brill. Now, I'm going to tell you very quickly about this guideline 252. I'm going to tell you a little bit about how we write nice guidelines. I was one of the committee members who wrote this guideline, so I have a knowledge of this guideline. I've been on other guideline development groups. I'll tell you a little bit how guidelines are written. I'll tell you a little bit how it's relevant to you and how you can use it. But I'm not going to take hours. So, first of all, what is nice? At the end of an afternoon of a busy Saturday, I think you'll think, this is nice. So we all like ice creams. How about walking on the beach with the dog, the sun going down, and Phil is about to go to Australia, and his sun will be going down later or earlier than ours in a few weeks' time. Or how about, I know this looks like a Welsh shirt. I have to pretend Wales can still play rugby and win it, but they will again. But some people like watching sport or playing sport. Those to you are nice. But I'm going to talk about today National Institute for Health and Care guidelines. And you hear on your televisions, NICE has approved this drug, and the proportion of people will think, oh, thank goodness, I'll get that drug that I need for my condition. Or NICE has rejected that drug. And some people in this country may be disappointed. But what these guidelines are, they're trying to make a case for using our scarce amount of money that we as taxpayers pay into our National Health Service wisely. And so the things that really do make a difference are encouraged to be delivered. NICE doesn't tell anybody they have to deliver it, and NICE doesn't give people money to deliver it. What it does, it tells our health authorities what they should be providing, and our commissioners what they should be commissioning. And so all the guidelines, often clinicians like myself get disappointed because they don't say you must have or you must do, because NICE cannot write a guideline like that. It says words like we would hope, recommend, try, refer, get. It doesn't say you must. So the guidelines apply to health, social care and public health, and are relevant in Wales as well. Scotland has its own guidelines. They're produced by a committee. This is an independent advisory group, so don't think it's full of drug company professionals or people with an invested interest. They're all independent. The committee members are made up of practitioners and providers. I often encourage my non-specialist colleagues, get yourself on a committee, because the guideline has to be something that in the real world will be relevant. So don't think because you're not a professor, you shouldn't be on a committee. Apply and you could then be appointed. And the committee members are not paid either. They are paid for example, Rachel was on this guideline with me, Rachel Keatley, you heard speak this afternoon. She's a physiotherapist. Her trust pays her salary. That is her payment for being on that committee. So we don't all get really rich and wealthy after being on a guideline committee. This particular guideline I've been asked to speak to you about, we got together in 2021. It's taken 22 people 4 years to write this guideline. It takes often a long time because this guideline, rehabilitation for chronic neurological disorders, including acquired brain injury, is a very complex. Can you imagine that? All our chronic neurological disorders in our population. It first of all decides what its scope is, what it's going to include in terms of what evidence it's going to look at. is relevant because you have to decide what you're looking at. And so we were not looking at adult stroke because there is a guideline already. This is guideline 252, and there is one on adult stroke. But there wasn't one in children's stroke, so we wanted to look at the evidence for what rehabilitation works in childhood stroke. It has to be, we asked the guideline committee, and behind the professionals I just referred to, there is the NICE Institute, who has this team of people who are expert at looking at the international evidence in English, usually over the last 10 years, and seeking out the papers which will be relevant to the scope of this guideline. And they bring then that literature to that committee member, 22 people, including lay members. So every guideline committee has to have people on it who are users of the service. And then those, that group will then weigh up the evidence and see whether it is of high quality, middle quality, or whether it shows there's no evidence. And ultimately, we make recommendations which are put in front of stakeholders. Now, this guideline, rehabilitation for chronic neurological diseases, including acquired brain injury, is relevant to rehabilitation in all settings. It isn't just for people in hospital, or it isn't just for people in community. It's all settings. It's all ages. Wow, you say. And so people like myself all the time said, what about the children? What about the children? Are we looking at the children? Don't just talk about college and employment. Talk about nursery. Talk about schools. And so it's relevant to all ages. It does not cover conditions which are already mentioned, as I said, in another guideline. For example, cerebral palsy, there is a guideline on that. And it should be read in conjunction with some other guidelines. For example, there is a guideline on best practice for adult brain tumours. Now, who's it for? Is it for your GP, or is it for the neurosurgeons in the back row? It's for everybody who's involved in providing or is a user. It's also for people who are working in related services. For example, teachers, employers, people working in housing and leisure, and people who are advocates for people with chronic neurological diseases. So it's basically, there is an ND in this room who this guideline isn't relevant for in some shape or form. Now, what does it say? It tells us how to design services. And when designing services, you should start your rehabilitation when people first develop symptoms. Have I heard this before today? Yes, we have. It should include your rehabilitation services, ability to give people lifelong monitoring. Have I heard this today? Yes, we have. It should include people in hospital and community. It should help people, encourage people to make use of other services. Think outside the box, the voluntary sector, private sector. It isn't just for people with specialist problems. It isn't just for specialist teams, for general teams too. And making the two of those work together. And we heard in our presentations today about the team here in Nottingham saying that they'd look into where the child lives. They know there's good community physio in that area. We'll get them to look after this child closer to their home. So it's for two-way communication between those services. A big part of this guideline says you must assign a single point of contact. And Sophie last night and all our individual voices we heard today talked about Nikki Webb, for example. They'd all talked about having somebody which they valued, who has been so helpful for them to call back into. And this is what this guideline is recommending, that should be available for all people with a chronic neurological disorder. And as part of that plan, for example, when you leave hospital, you should say, who am I to contact in 10 days' time or 10 months' time if I have a problem? And that is the key worker. Now, in the teams I've worked in, we don't have somebody, this is Miss Key Worker or Dr. Key Worker. We'll say between ourselves, who knows this patient the best? Who's getting on with this patient the best? Who's seeing this patient the best? And you become the key worker. And so when they leave hospital, they say, who shall I contact? And we say, phone that person's secretary, or this is the email. Or it could be the team. You haven't got to spend a lot of money on a salary. And with Javid, the rehabilitationist, said he was thinking how to accommodate people with brain tumour into his service and do the acquired brain injury. So he's added it on to the Botox team, he said. So teams needn't always feel that they need to buy a new person. Sometimes you can work imaginatively and flexibly in your own teams as they're working. And so that is helpful. It may be a new thing for some teams, but it is the way we've worked quite well in the services I've worked in for a long time. But this is a key theme. And as a user, when you leave hospital, you should say, who should we phone back? Feel confident. Who should I be phoning back if I have a problem? And they should be able to give you some name, address, email, number. There's a huge chapter in this about rehabilitation for chronic neurological in the guideline about support children back into education. And I can't stress enough that is, and you know here how important that is. And it refers to this two-way communication. You should inform outreach to the school, college or setting. They, again, need to know who they phone up if they're having difficulty in some area with their student. There are sections on designing services, assessing needs, planning, information advice, maintenance to support improvement, return to education, work, social leisure, and relationships, including sex education. And Helen keeps on talking about sex. You don't really, Helen, but you certainly talk a lot about hormones and research recommendations. So I was asked to say this. Does this actually, though, apply to children with brain tumours? So it is in the heading, this applies to people with a chronic neurological disorder, Parkinson's, MS, rare diseases, and acquired brain injury. And in the glossary of terms, acquired brain injury is an injury to the brain that results in an impairment secondary to trauma, tumour, infection. So it very much applies to the population that Success is working so hard to help. And who refers to rehab? Well, it's all our business. So it could be the nurse who says, oh, I'll get the physio to see you. It could be the physio, OT. We all have a responsibility. In primary care and secondary care, it's worthwhile they knowing who they would refer to. And we heard today that Javid would accept referrals from a GP in this area for if a person had had an acquired brain injury. They haven't got to be able to be very knowledgeable about it, but they have to know where to access it. Now, what do you do now in your teams, in your families? So first of all, you're now aware of the guideline. Check it out. Look at it. If your team you think is not making the grade, where are your gaps? Can you put in your next business plan? When somebody leaves, could you imaginatively change their job plan? Is there an initiative that we have? Sometimes we call it initiatives where we are asked for new ideas. Should we just go to our commissioners and say, what are you doing in this region? So those are ways that we have found that have worked for us here in the East Midlands, and I suggest they could work elsewhere. Success Charity is wanting you to achieve. So, there is no money in this guideline, but it is a lever. And so we all have to use what's available to us to enhance, extend, inform, aid people to achieve more, to get that success for you and your population. And I think the gold is at the bottom of that rainbow, and we can do better. We can all do better. And I hope this guideline will help people improve services for those who need it, like we've heard today.